when I do, I'll be sure to cross-reference this particular video, so you can see a pre and post infection. Now, what happened though, although the active infection is now resolved, the residual discharge has crystallized, and there's also a thick layer of skin that's adhered itself to the medial ear canal and also the eardrum. So we're going to try and peel this away. The patient also reported that since the infection and after reinserting the hearing aid, because we advised them not to wear the hearing aid whilst they were infected, that the hearing aid suddenly began to whistle, and it never previously did. So hearing aids can whistle, and when they do, we call that acoustic feedback. And acoustic feedback occurs when amplified sound into the ear via the hearing aid escapes back out of the ear, and it re-enters the hearing aid for a second time, which then causes the hearing aid to re-amplify that sound that it has already amplified back into the ear. And once again, that re-amplified sound escapes back out, and it re-enters the hearing aid microphone again. So you get this vicious cycle, we call that a feedback loop, which then results in the hearing aid whistling and squealing. It's not only audible to the patient, although sometimes the patient themselves can't hear it, but also people in close vicinity to the patient can hear it. So it can be really annoying. So I'm just trying to peel away the skin using the fine end. I'm trying to do this in a dry approach. I don't want to use any olive oil spray because they've just recovered from a fungal infection. Sometimes the addition of olive oil back into the ear can give rise to the fungi to recolonize and begin to reproduce and exponentially grow, because the fungi enjoy feeding off the olive oil. So I'm going to do this without using any drops if it was possible. So I'm just now peeling some of this crystallized skin and residual discharge that has been treated by their medication off the inferior, so the bottom part of the ear canal, and also the front section of the ear canal. This is the anterior wall. It's quite adhesive. And I'm just lifting it up and away. So fungal infections, they account for about 20% of all ear infections. I would possibly, that's cited data from various studies. I would be inclined to say that maybe fungal infections are probably a bit more common than that, but instead they often go misdiagnosed as a bacterial infection. If it's an aspergillus range of fungal infections, so Aspergillus niger or flavus, for example, they are quite noticeable because typical landmarks that are present in the ear are, as I mentioned before, fungal spores and also hyphae, so woolly strands. And you can see these spores moving around, especially before the microsection. Whenever I see an aspergillus strain of fungal infections, the hairs at the back of the neck stand up and you see those spores and the hyphae. Candida is the one that can sometimes go misdiagnosed because you get a thick creamy discharge, but sometimes you can get bacterial infections that give a similar appearance. There are other ways of differentiating between a fungal and bacterial infection, but they're not always bulletproof. So for example, a lot of people with fungal infections don't actually experience any otalgia. Their main symptoms are itchiness of the ear, and obviously reduced hearing and fullness. Where more often than not, but again not always, with a bacterial infection, it can be painful for the patient. And actually one of the bedside diagnostic tests that are performed to diagnose an ear infection, more specifically bacterial ones, if you apply pressure on the tragus. So the tragus is the piece of triangular cartilage just outside the entrance of the ear canal. If you apply a bit of pressure on that and almost push that in towards the entrance of the ear canal, if that's painful for the patient, then you can diagnose an otitis externa, so an bacterial infection. Now, fungal infections typically occur when the environment, the ecosystem of the ear, is disrupted and changed. Our ears are actually full of native bacteria and fungi, so they're native to the ear. We call that skin flora, and under normal conditions they're non-pathogenic, they don't cause any harm. However, if the condition of the ear changes, for example, if you cause a physical trauma, so a microabrasion or abrasion, for example using a Q-tip, if you get water in the ear, which then changes increases the pH level in the ear from mildly acidic to more neutral or alkaline, and also moisture due to the water, and increased temperature, so increased humidity. These are all potential risk factors of the natural ear environment being changed and disrupted, which then gives rise to some of these native bacteria that then become suddenly pathogenic, alongside the fungi present in the ear. And it can also allow other non-native bacteria to enter the ear and become pathogenic. So this patient is prone, unfortunately, they are a chronic sufferer, and they've been receiving treatment for many years for their chronic infections, and it's unfortunate with this particular patient. It's just a matter of keeping on top of it and cleaning their ear on a regular basis. They are ensuring their ear ears are dry, there's no water getting in there, but they do wear the hearing aid, as I mentioned previously. In some people that can cause increased humidity and sweat, which can then lead to an infection. A small percentage of people are actually allergic to the plastic used to make hearing aids. They're typically hard acrylic. They can have a hypoallergenic soft coat applied, which can help. Wherever possible with the hearing aids, we want to also ensure we ventilate the ear, because if you've got a closed hearing aid, so a hearing aid that completely seals the ear canal, as mentioned before, it can lead to increased perspiration, sweat, humidity in the ear. So wherever possible, you can vent the hearing aid. Some hearing aids have natural vents. They have a mushroom dome attached to the end that goes into the ear with air pockets, so they naturally aerate the ear. Other hearing aids are custom made, so they fit into your ear like a jigsaw piece. You can request a ventilation hole from the manufacturer, so it's a hole that's drilled all the way through the hearing aid, so it just allows some natural air inside. If some people, especially if they've got a severe to profound hearing loss, if the ventilation hole is too big, that can also then lead to whistling of the hearing aid, because a lot of the amplified sound can escape through the vent back into the hearing aid microphone. But wherever possible, I always, although I don't prescribe hearing aids anymore myself, but when I used to, always try and ventilate the ear as much as possible for the patient. So just peeling away this thicker layer of skin from the roof of the ear canal. So we begin to see some of the eardrum just off left of screen, and you may be able to now take notice of this dead skin. When we first visualised the ear, you may have not noticed that there was some skin on the ear, but it's only sometimes when you start peeling it away, when it reveals a healthy looking eardrum, that you kind of notice and realise there was some debris on there in the first instance. So it can sometimes again go unnoticed when you've got a thin layer of skin, or even a thicker layer of skin like this, because the skin itself can be translucent, so it doesn't fully disguise and hide away the landmarks we associate with the eardrum. So our eardrums have got several landmarks. You've got the hammer bone itself, which is the first of the three middle ear bones. You should normally be able to see that. At the centre of the hammer bone, you've got the umbos, and that attaches to the eardrum itself. It's sort of like the bullseye of the eardrum. You've then got the short process of the hammer bone, which is the top section, but you have a spherical projection of bone. So when you've got dead skin, because it's translucent, you can still see the eardrum through it, so you may not always realise there is a layer of skin coating it that needs to be peeled away. So we can see the top half of the eardrum now. And because it is so dry, it does make it a bit more tricky, and we just got it, and it's because it's more adherent. So when I'm peeling this away, I want to go down, or previously I was going side to side. I don't want to pull it directly. Hence why I resisted the urge to use forceps. Because forceps, sometimes you can apply, the way you grab it, the angle, and you're pulling away. We don't want to rupture this patient's eardrum. So I'm trying to peel it in a sideways motion. Of course, if I used a bit of drops, it may have helped, but for the reasons described earlier, I want to avoid any form of drops in this ear, because the patient has just recovered from an infection. So it's vitally important to keep the ears dry as possible. Slowly but surely we're peeling this away. There's a bit of skin that's attached to the umbo region, to the centre of the ear, just there. A bit more callous piece of skin, a bit thicker, a bit more drier. Pull that down. And slowly, I think I've released it now. And a bit of the skin at the bottom that's still attached. So once I've removed all this dead skin, the patient's hearing aid immediately stopped whistling, so we're pleased with that. So I'm momentarily going to go with a bigger vacuum. Yeah, there we are, just to get this last piece away. So one more sheet of dead skin, which is attached to the posterior canal wall, the back part. You can see it there's attached to the ear canal wall. So it's not actually on the eardrum, this is just off the eardrum. Peeling it away, I've got to just be careful that the fine end suction probe doesn't make contact with the opposite side of the ear canal, because I'm applying a bit of pressure to pull it away. You can see there we came in close contact, so I just got to be wary of that. With the skin, you can see the matrix formation there, the texture. So you can visualise the whole eardrum. There's just a bit of skin here in the midsection of the ear canal.